Maybe I'll just start our recording here. Welcome everyone to our weekly UCSF Orthopedic Surgery Grand Rounds. Today we have a special visiting professor from University of Colorado, and for an introduction, I'll turn it over to Dr. Pasquale.
Thanks, Drew. We're so very pleased and excited to have the opportunity to welcome Dr. James Carollo as our Grand Round speaker today. When the faculty of the PM&R section was contemplating who might be a great speaker for us to invite, we definitely wanted someone with expertise in a clinical area that is near and dear to our PM&R hearts, but we also wanted to have someone whose clinical and research interests would truly resonate with other faculty members of our department, as our team consists of surgeons, primary care, sports medicine physicians, podiatrists, researchers, and prosthetists and orthotists. So what better topic could we find all that collective interest in but gait and movement, not only in children, but also in adults. Dr. Carollo comes to us from Texas. He's trained as a bioengineer. He received his undergraduate and master's degrees from Texas A&M and his PhD from the University of Texas Southwestern. His many areas of interest include gait and motion analysis. That includes cerebral palsy, sports medicine, and musculoskeletal disorders. When asked, Dr. Carollo will humbly tell you that he's just a biomedical engineer that has had the good fortune over his career to design and build clinical gait labs, but he really wears many distinguished hats. He is the Tai Endowed Chair and Director of the Center of Gait and Motion Analysis and the Director of Musculoskeletal Research at Children's Hospital, Colorado. His gait lab is the first and only clinical movement analysis lab in Colorado, and the only program in a children's hospital that treats both children and adults. He's also an associate professor in multiple departments that include the Department of Physical Medicine and Rehabilitation, Orthopaedics, and Bioengineering at the University of Colorado. While I've only had the pleasure of meeting Dr. Carollo this morning, one of our colleagues, Teron Davis, is an alumnus of the University of Colorado Pediatric PM&R program and would like to say a few words before Dr. Carollo starts the lecture.
Yeah, thank you, Dr. Pascal. Yeah, I was really thrilled to offer the suggestion to have Dr. Carollo come and talk with us. First got the opportunity to work with Dr. Carollo in my training, and during that time, there would be these multidisciplinary gait lab reviews where like titans of the UC campus would come together with Dr. Carollo, Dr. Frank Chain in orthopedics, and Dr. Dennis Matthews from Physical Medicine Rehabilitation. I would just see these guys just bat these ideas of gait abnormalities and what to do, and what Dr. Carollo always seeming to be the voice of reason of like what the pattern is seeing between the fighting orthopedics and physiatrists point of views of like what they surgery versus non-surgical interventions, and really seeing Dr. Carollo kind of mediate that and provide quite a bit of education along the side, even though it was kind of drinking out of trying to consume as much information as possible, and so Dr. Carollo has also been a wonderful research mentor for me. We started working on a project back when I was in residency about surgical outcomes in pediatric populations with cerebral palsy, and he's worked and he's been a wonderful advisor as I've made the transition to UCSF, talking with our committee looking to reinstitute the gait lab for pediatric evaluations here, and so I'm really pleased and thrilled to welcome him here today.
Well, thank you very much. Wow, that's awesome. It's really very it's an honor to go ahead and present to you. And Dr. Davis, it's great to see that you thought that this would be useful, and I hope that we can, that this presentation will meet your expectations. Let's see here. So one of the reasons I'm thrilled to be presenting here at University of California, San Francisco is because you have some very distinguished alumni from here that I have to mention. And the first is Dr. Vern T. Inman. And it's been a long time since Dr. Inman has been at University of California, San Francisco. But it's safe to say that he has been the father of biomechanics in locomotion. And when I read his book, Human Walking, many years ago, it gave me the inspiration that engineers and physicians could work together to be able to solve these complex problems that present themselves in locomotion. And so I feel very honored that I have an opportunity now to present. You know, when I think about his book, I think back to all of the things that he was able to do before we had the toys we have today. We didn't have computer-based systems, and he had to invent many of the tools that were necessary. But the thing that stands out when I look back at his book are these incredible illustrations, because he had a gift for being able to communicate what was going on during the gait cycle. Not only did he develop the tools for being able to measure EMG from a moving subject, which is not trivial using the electronics of the 50s, but also he was able to have this great way to communicate it. And I still rely on this. I love these illustrations. In this particular illustration, he's indicating the timing of muscle activity, and rather than just looking at charts, he's choosing a saturated color on the top for the gluteus maximus, hip extensors, and then at the bottom for gluteus medius. And you can see very clearly that these muscles have to fire and have to contract during weight acceptance on the stance limb. The solid black limb indicates when those muscles are at maximum. And you can see that most of the time muscles are not firing. If you add in the quadriceps, you can see that they too are firing when you're making and breaking contact with the floor, with the exception of the rectus femoris, which is firing right at pre-swing, right as the foot is leaving the ground, in an effort to in its functioning in its hip flexor job to advance the limb. You can see that the hamstrings too are also firing at the time you're making contact with the floor, and they fire a little bit early to be able to decelerate the swinging limb and prepare it for weight acceptance. Tibialis anterior, he shows very clearly the maximum contraction is when it's functioning as an eccentric dorsiflexor, firing eccentrically to lower the foot to the floor if you have a heel first initial contact, and then firing at a lower level in concentrically, which in gait, eccentric muscle contractions dominate. And this illustration really sent home to me this phasing response where the triceps suri is out of phase from the tibialis anterior to be able to perform this wonderful symphony of activity that goes on around the ankle that we call the three rockers. And so in general, he concluded that most muscles are active at the beginning and end of swing and stance period, and that despite the fact that there's maximum displacement in the middle of the gait cycle, that's at a time when you only have a small number of muscles that are active dynamically. In particular, the triceps suri, gastrocnemius, and soleus, which are all trying to contain the momentum of moving forward. And I think Dr. Inman really personified all of this in his original book. And so, he is who first pointed out that principal action of muscle is to accelerate or decelerate angular motions of the leg. And that once you build up the momentum, the job is to go ahead and try to constrain motion. So that was very important, and he was a pioneer in that. But he also had the good fortune, and Dr. Perry had the good fortune to study from him. Dr. Perry is your other very well-known alumnus that has been involved with movement analysis, and she attended medical school and on the GI Bill and did her orthopedic residency. I understand she was the first woman orthopedic resident at UCSF. And as a result of that, she then went to Rancho Los Amigos National Rehab Center and then proceeded to have a 60-year career in clinical movement analysis. So I felt that rather than showing you lots and lots of graphs, I'm always happy to look at that. And during our meeting with the residents for Journal Club, we did look at graphs and interpret those. But I'm going to be giving you the important pieces of what Dr. Perry had identified associated with the critical events of normal gait and give you some examples of what that looks like when these critical events are missing. Because at the heart of this, instrumented movement analysis is a great tool, but you still have to use it in conjunction with your observational skills, which are, and I've found that her approach has really enlightened us in terms of how to utilize instrument gait analysis to better understand. So these are my learning objectives to provide this overview of the 8 phases and 13 critical events of normal gait, and then provide some patient examples that illustrate what happens when those critical events are missing. And this is applicable whether you have a gait laboratory or not, but if you do, you can utilize that information to make better results. So everybody knows, is familiar with this. Gait is a cyclical phenomena, so there's a cycle. Begins and ends with initial contact. About 60% of the cycle, there's a foot off, and it separates the cycle into stance period and swing period. There's 2 periods of double support, separated by a single limb support period. And as you increase the walking speed, the double limb support periods get narrower and narrower. That's followed by a swing period of about 40% of the gait cycle. What you may not have seen is actually consider this timeline, instead of just being a linear line, but wrapping it around a unit circle. And if you wrap this around a unit circle, like I show here, you really start to appreciate these important symmetry perspectives. Dr. Inman always talked about that gait. There is no particular reason to benefit one side versus the other. And as a result of that, when you wrap this around the unit circle, you see that these temporal events, i.e. making and breaking contact with the ground, it's called initial contact or foot off, they actually appear on the unit circle 180 degrees apart. And so in normal walking, there's no priority for the left or the right side. You would expect these to be there. And this really does demonstrate the symmetry that should exist when you see it. So always keep in mind when you're watching someone walk, that if there is asymmetry, there's no particular functional reason for that asymmetry. And if you look so that if you look at the timing of these foot floor contact patterns, it can provide great insight into where the disability may lie. With these, you break up the gait cycle into time periods, and you can get timing for that you can compare between the left and the right side: stance time, swing time, double support time, single support time, and step time. And by comparing these from side to side, you can get a good sense of where disability may lie. Now, to be able to break this up, and the contribution that Dr. Perry has made to this is that she identified that not only do you want to break it up just based on time and the existence of double support periods, but you also want to break it up serially, but from a functional standpoint. And so to facilitate that, she added 3 additional temporal events. One in stance phase that she refers to as heel off, and that's obvious. That's the point where the heel leaves the ground and the axis of rotation moves to the metatarsal heads. But there's also 2 in swing period, feet adjacent and tibia vertical. She chose these because of the focus that this technique has on observational movement analysis. And feet adjacent is when the swinging limb passes by the stance limb, and tibia vertical is just that, when the tibia is vertical to the ground. So if you can identify where these are, along with foot floor contact patterns, you can break up the cycle into the phases of gait that she has identified. And so this is just showing you a conceptual drawing of showing the temporal events around this unit circle: initial contact, opposite foot off, heel off, opposite foot strike, terminal contact or foot off, feet adjacent, tibia vertical. And these mark the delineation between these phases. And this is important because if you're going to do observational movement analysis or do your own assessment or apply the critical events, you have to know what phase of gait you're in. And you can use these temporal events to be able to divide the gait cycle up in that fashion. So I'm going to march through this very quickly, go back to a linear model. So we have initial contact is both a phase of gait and a temporal measure. Loading response is then the period of initial double support. It ends with opposite foot off. And then this, Dr. Perry identified as the task of weight acceptance. And so there's several things, she identifies important criteria that have to happen during this weight acceptance period. Mid stance then follows. Heel off is the end of mid stance. That begins terminal stance. And then this ends with opposite initial contact. And these two phases are part of single limb support. Interestingly enough, the second double support period in her nomenclature from a functional standpoint is considered pre-swing. And the importance of this is that not only are you transferring weight to the contralateral side, but pre-swing is also the time when you are preparing the limb for limb advancement. And so if you are going to have a successful limb advancement, everything is done during this pre-swing period. That ends with foot off. And then you are in swing period, which has an initial swing that ends with the feet are adjacent, mid swing when the tibia is vertical, and then terminal swing that ends again with initial contact, and then the cycle repeats itself. And all of this is part of the task she identifies as swing limb advancement. So given this framework and being able to break up the gait cycle, Perry's identified 13 critical events of normal gait. She considers these critical because since each of these events must be performed during the appropriate functional task if normal walking is to occur. If a critical event is missing or altered, it reflects specific gait impairments, and therefore the intent is that intervention should focus on restoring these critical events. So now I'm going to march through some of these critical events and give you some video examples of what it looks like when they're not there. So at initial contact, it's here the critical event is heel first initial contact. So it must be present. It's necessary so that you can redirect and preserve the momentum you've built up during the swing period and the forward progression of the body, but it also allow a smooth transition into stance phase. There's then three critical events that occur during loading response. Controlled knee flexion. The purpose here is to provide shock absorption. This is provided by eccentric contraction of the quadriceps. We saw from Dr. Inman's illustrations that the quadriceps are active during this period of time, and this is their highest demand to provide shock absorption during weight acceptance. Then she identifies hip stability. This is dynamic joint stiffness in the sagittal and frontal plane to prevent unnecessary pelvic tilt. And so these are eccentric contractions of the hip extensors and of the hip abductors, the gluteus medius in particular, to be able to go ahead and prevent excessive pelvic obliquity. And when that occurs, it presents a particular gait pattern that we can recognize. The final one is controlled ankle plantar flexion, and it's also it's referred to as the heel or first rocker. This is basically preparing the limb for weight transfer in a plantar foot position, and it's controlled by eccentric contraction of the dorsiflexors that pulls the tibia forward to stabilize the entire limb, and then this actually has a stabilizing effect all the way up the kinematic chain because the quadriceps are also firing at this time, and this provides the stability to accept weight and prepare for single limb support. Now I'm going to just talk briefly about this is a good introduction to the three rockers. And so the three rockers are referred to as the heel rocker, the ankle rocker, and the forefoot rocker, or the first rocker, second rocker, and third rocker. And the heel or first rocker is controlled ankle plantar flexion during WA, which stands for the task of weight acceptance. Your axis of rotation is at the heel. It requires a heel first initial contact to achieve. It's eccentric, so it's a lengthening contraction of the tibialis anterior. And during this time, you're absorbing power. And the chief goal is to go ahead and lower that foot into a plantar grade position so that you can accept weight. As the center of gravity moves over the base of support, you move into the ankle or second rocker. This is controlled. This is considered controlled tibial advancement. When we say controlled in gait, it's always referring to some muscle is doing a lengthening or eccentric contraction. In this case, the gastrocnemius is firing, and it's firing during single limb support. It's pivoting at the ankle, and again, it's power absorption. And as you saw from those illustrations, the gastrocnemius is firing throughout stance period to control this entire limb, and it's the dominant muscle during that period of time because it's trying to contain the momentum built up, and it's all being contained about the ankle. And then the final rocker is the forefoot rocker. As the center of gravity of the body advances over the stance limb, it limits the increased gastroc activity limits dorsiflexion and stops it, so the slope is near zero. And then it turns around into a concentric contraction where they're now generating large amounts of power. This is in preparation for the next phase, transferring weight and preparing the limb for the phase of pre-swing, where you transfer weight and prepare the limb for limb advancement. So the first comparison I want to show you here is this particular gait pattern, and this is the toe-toe gait pattern that you see. Obviously, the critical event of heel first initial contact is absent in these toe-toe gait patterns. And so this on the left, this is a 5-year-old child with spastic diplegic cerebral palsy, and you can see that it's a clear toe-toe pattern. On the right, we're showing another child. You might think it's the same child. It's another 5-year-old, but in fact, it's a different child. The activity you see on the right side, we're not really paying attention to that. That is a EMG recording, so that's giving me a real-time recording of the electromyograph, so we can look at timing of muscles during movement. What I'm focusing on here, though, is really just the observational pattern. We're interested in taking a look at this. And so while both of these seem very similar, I hope that you can notice that, in fact, they are two different patterns. On the left is true equinus, which means that there is a excess plantar flexion. And when you look proximally, you'll see that the knee achieves knee extension, and there's not an excessive amount of knee flexion at weight acceptance or initial contact. Whereas on the right, this is an example of parent equinus. So observationally, they both are toe-toe gait patterns, but there's a big difference. Murray Goldstein, who of the United Cerebral Palsy Foundation, had identified that failure to recognize apparent equinus is the most common error in observational analysis. And he says it's more than academic importance. It actually has great significance because if you inadvertently go after the heel cords because of the toe-toe pattern to get a plantar grade foot, you can have a bigger problem when you're finished because it can slip the child into crouch gait, which is characterized by increased hip flexion, knee flexion, and ankle dorsiflexion. And that is a more severe and more energy consuming pattern. And so it should always be recognized. So in true equinus, it has forefoot initial contact, but there's plantar, there you see that there's plantar flexion at the ankle. And you can observe this observationally, and you should be looking for that excess plantar flexion instead of in the apparent equinus situation, where proximally it's characterized with increased hip flexion and increased knee flexion and a more neutral angle at the ankle. And so that's where movement analysis can help. If you look at the kinematic curves, you can compare them to normal, and you can actually identify if excess plantar flexion is there, but you can observe it as well if you go ahead and pay attention and know what to look for. So that's a circumstance where the heel first initial contact is not there and we're missing that critical event. So moving forward now, after the initial contact period, we now move into loading response. And the first here is controlled knee flexion for shock absorption. So here I have a subject. This is a 6-year-old child with spastic diplegic cerebral palsy. I hope we can see now by looking at that ankle that there is truly excess plantar flexion that's leading to this 4-foot initial contact. So we would characterize this as this true equinus pattern we just noticed. And what you'll see is that these critical events often cascade into other adjacent phases of gait, and they may cause additional critical events to be absent or altered. In this particular case, you can see that at weight acceptance, instead of having a controlled knee flexion, the normal knee curve that allows us to have shock absorption, there's a coupling between the ankle plantar flexion at weight acceptance, and it's exacerbated a bit by the forward trunk lean she has and by walking in this walker. As a result of that, there is a coupling between the ankle plantar flexion that forces the knee back into knee hyperextension, or at least to full knee extension. That eliminates that knee flexion curve that we would expect to see, and causes something that we refer to as the plantar flexion knee extension couple, or PFKE couple. And the plantar flexion knee extension couple can be both a good thing or a bad thing. If you have excess knee flexion at mid-stance, inducing a plantar flexion knee extension couple can improve knee extension at terminal stance. But when it happens early during loading response, it eliminates the loading response peak that you would typically see at the knee. And as a result of that, this eliminates the shock absorption function and is an abnormality. In this young child's case, this is caused by spastic response in the ankle plantar flexors, and so it's not uncommon to treat this with Botox injections. But she was able to go ahead and still wear a solid AFO, or wear an AFO in this, and so we tested her in this AFO at the same time. And I want you to kind of appreciate that even with an AFO, while there still is an attenuation of the loading response peak, you can see now that it's not as forceful going into full knee extension. And so we are improving the plantar flexion knee extension couple and moderating it just by reducing the driving force to that plantar flexion knee extension couple. You could further improve this by having a slight amount of dorsiflexion in the AFO, but you can see that just by simply using an AFO, you can attenuate that plantar flexion knee extension couple and improve the shock absorption at the knee. All right, so this is an example then of controlled knee flexion and loading response improved with an AFO for the individual with true equinus. So now we've talked about controlled knee flexion. We're going to look at hip stability, and again, this is a dynamic joint stiffness in the sagittal and frontal plane to prevent unnecessary pelvic tilt through the control of the hip extensors and hip abductors. So this is in two planes when we refer to the hip stability. So as an example of this, this is a 13-year-old young lady with spastic diplegia, and she has a compensation where the hip stability is compromised. And if you look closely, especially from behind, you'll notice that there's a lateral trunk lean to the right during weight acceptance. So again, you need to be able to try to identify what phase of gait you're in. And if you see her as she walks away from us, you should be able to see that there is a lateral trunk lean. It's actually, we found that that folks who have a ponytail sometimes give you a telltale sign that there is a lateral trunk movement to the side, because the ponytail will give it away. And if you notice, the ponytail is leaning toward the right side during loading response. So this is a compensated Trendelenburg. The intent here is to go ahead and move the torso to the weak hip abductors and thereby reduce the demand on the hip abductors. So it's compensated in an effort to try to hold the pelvis up. But if you look at the contralateral side, at the left side, she does not have that travel. And if you notice, right at weight acceptance, you'll notice that the pelvis drops on the right side. That's actually an example of an uncompensated Trendelenburg gait pattern. So she actually displays both compensated and uncompensated Trendelenburg during that time. And both of those are examples of a instability at the hip. She compensates by reducing the demand on the hip abductors on the right side, and she compensates by just allowing her pelvis to drop a little bit more on the right side, which is basically showing that we're reaching a threshold of force production by the hip abductors. So this is an example of what Perry has identified as maintaining hip stability. Both of these, the hope is that we can have strengthening exercises so that we can improve the strength of the hip abductors and minimize some of this compensated and uncompensated activity. So the last critical event during loading response is controlled ankle plantar flexion, or the heel rocker. And I talked about this already to a certain extent. For the heel rocker, if you achieve a heel first initial contact, you need to lower the foot to the floor, and that's under eccentric control of the dorsiflexors. That provides stability for the entire limb when it co-contracts with the quadriceps. And so here is an example of a 6-year-old spina bifida patient who has clearly weak tibialis anterior. And if you notice, it looks like many times she has a foot flat initial contact, so she's compensating by, but you can see that on the right side, she does make contact with her heel, but her foot slaps down very quickly. That foot slap sometimes is audible if it's very pronounced, but in her particular case, it's just a very rapid example of what happens when you are not able to control the demand on the ankle dorsiflexors during weight acceptance. For her, the best solution again is an AFO. And if you notice now, this is her at the same time. Now that you can look at the right side, we have reproduced this normal ankle mechanism just by being able to provide some plantar flexion control with the AFO. And now she's able to have a heel first initial contact, and that controlled ankle plantar flexion as she accepts weight sets her up for a stable platform and sets her up in a position where she can have good knee flexion during weight acceptance. And so this is an excellent solution. And so this is not uncommon for kids with spina bifida. to be able to have an orthotic solution that can return that critical event that's missing. All right, so those are the critical events associated with loading response. We now are going to move forward into the critical events associated with single limb support. At mid stance, we have controlled tibial advancement, which is the ankle rocker. So now the center of pressure has advanced over, and the foot is plantargrade. So now, as the center of gravity moves further, you have to control the amount of dorsiflexion. So it provides support against gravity and prevents premature dorsiflexion of this, and the subsequent excessive knee flexion that occurs by eccentric contraction of the ankle plantar flexors. And as we saw, even from those illustrations, the ankle plantar flexors are on throughout stance period. And as the center of pressure moves across the foot and advances further along the foot, we see a increase in the ankle plantar flexors as the demand increases. During terminal stance, there are two others: controlled ankle dorsiflexion with heel rise. This is the forefoot rocker, the third of the three rockers. This is continued eccentric contraction of the ankle plantar flexors. And as that occurs, eventually the axis of rotation shifts to the MP joint, lifting the heel. The plantar flexors change to concentric contraction near the end of terminal stance in preparation for the rapid ankle plantar flexion that follows during pre-swing. And another observational sign is trailing limb posture. And then this is characterized by full knee and hip extension as the body advances in front of the foot. And its main purpose is to contribute to a longer step length on the contralateral side. So the obvious example here is individual with crouch gait. Now, this particular subject is an 11-year-old with a chromosomal abnormality, also has autism, and in general, overall weakness that's characterized here. This is a good example of how when crouch gait occurs because of premature advancement of the tibia over the talus. You can see that he initially accepts weight and the tibia is already past vertical, and the weakness in his calves contributes to this, what is sometimes called a calcaneal gait pattern. But because of that, the tibia advances quickly over the talus, and you get increased knee flexion throughout stance period. In his particular case, he does not have knee flexion contractures. And so this is being driven from the floor up, and the weak calves contribute to this increased crouch gait deformity. Again, an AFO is a good solution here to be particularly a solid AFO or a ground reaction AFO. But sometimes in these kids with autism, the sensory feel of having an AFO is not tolerated. And so in his particular case, we did not have a good solution for being able to improve this because the recommendation of AFOs were not followed. However, this is an excellent example of what happens when the tibia has excessive dorsiflexion at terminal, during the single limb support task, starting in mid stance and ending in terminal stance. I couldn't do this without including a crouch gait deformity associated with cerebral palsy. It looks like this is not playing for me. Sorry about that. I can frame advance it, but it doesn't appear to be playing. So my apologies here, but I will advance it frame-wise. And in this particular circumstance, just notice the top two traces on that dynamic electromyogram. The loading left, the LRF is the left rectus femoris, and the LVL is the left vastus lateralis, if you'll notice. And the far right side of that is the activity that's necessary. You'll see that as soon as you accept weight, the magnitude goes to full on magnitude and the vastus lateralis continues. Sorry about that. I'm not sure why this isn't playing for me right now. There we go. So this is just to indicate that with 70 degrees of knee flexion during weight acceptance, this is a tremendous demand on the quadriceps. And so you typically are going to see prolonged activity out of the quadriceps as well as prolonged activity out of the gastrocnemius because of the demand that's placed on it. In this particular case, there is a knee flexion contracture, and this crouch is manifest by spasticity. And in these circumstances, we do utilize the distal femoral extension osteotomy and patellar advancement procedure. This is the child about 18 months later after this procedure. And the difference here, and I did include some kinematic curves here, the dotted line at the knee curve shows you and demonstrates the significant knee flexion that's present during loading response, and the improvement that you can get from this particular procedure. And you can see that as a result of that, we get a much more upright posture. And then you can see that while with significant crouch, there's no dynamic range in the knee curve. It's very flat. By doing the distal femoral extension osteotomy and then the patellar advancement to relocate the patella so that the moment arm can be maintained, you get greater efficiency out of the quadriceps. And while you still have a pattern that's not ideal, and it's a significant improvement and much less laborious than the pattern we saw with severe crouch. And this continues to be a tool for us when it's spasticity driven and contracture driven crouch gait. All right, in the few minutes I have here remaining, I wanted to finalize this with the critical events in swing limb advancement. And so the critical events that are here are passive knee flexion to 40 degrees and rapid ankle plantar flexion during pre-swing. These are important because these are the times when power is being generated during the gait cycle. The passive knee flexion to 40 degrees means that you need to get at least halfway to full knee extension, knee flexion before the foot ever comes off the ground. And it's the combination of the rapid ankle plantar flexion that drives the tibia down, as well as the transfer of weight that allows you to get passive knee flexion. We call it passive knee flexion because, in fact, the hamstrings do not fire during pre-swing. The reason the knee bends is because it's a closed kinematic chain. There's power generation, positive power generation from the hip flexors, and there's positive power generation from the ankle plantar flexion. And all of this serves to basically flex the knee as a result of these two power generators above and below the knee. And it's, again, it's often fascinating when you see that the hamstrings are not active during this period of time. If you are successful at achieving passive knee flexion to 40 degrees and rapid ankle plantar flexion, then you can actually flex. You are setting the limb on a ballistic path to achieve these other milestones that we look for. First, in initial swing, we want to achieve knee flexion to 60 to 70 degrees. So we finish the knee flexion that we started in pre-swing. Again, pre-swing functionally is part of swing period, but technically is part of stance period because it's equivalent to the double support period. But if you don't achieve these critical events in pre-swing, you're never going to achieve 60 to 70 degrees of knee flexion in initial swing, which is a time you need to have that maximum knee flexion to be able to pass the limb directly under you without compensatory movements. The next step is mid-swing, and so when the tibia becomes vertical and through to when the starting when the tibia passes the stance limb and continuing until the tibia is vertical, you need to have achieve your maximum hip flexion of around 30 degrees. Too little is not enough. Too much is not good either. And you also need to have a neutral ankle position so that you can have foot clearance. And then at terminal swing, the final critical event is to achieve knee extension to neutral. Again, this increases step length, but is dependent upon having a trailing limb posture on the contralateral side. So as an illustration of these critical events, I'm showing an example of an individual. This is an 8-year-old with left spastic hemiplegic cerebral palsy and what we would define as a left stiff knee gait. If you notice, look at during the second double support period, the pre-swing period, and you see that there's not 40 degrees of knee flexion during that time. So she's failing on that. She also does not have much of a plantar flexion. Part of that is a rotational abnormality because she has what Dr. Gage has referred to as lever arm disease, which means that you're not able to use the lever arm of the ankle because we're externally rotated. But that's coming from the fact that she's not able. That's a compensatory movement, as well as the circumduction she's using. That's a compensatory movement from the primary abnormality, which is lack of knee flexion in pre-initial and mid-swing. So this is a common abnormality. These are the knee curve that you typically see. In her particular case, she has a significant deficit. She's lacking 50 degrees of knee flexion. And as a result of that, it leads to increased tripping and falling. It's energetically inefficient and causes a series of compensatory movements on the ipsilateral side, such as hip hiking and circumduction, and on the contralateral side of early heel off or vaulting. One solution for this, and this is where instrumented gait analysis is really necessary, is to be able to actually record the timing of the rectus femoris. And we know from the literature and from other studies, not only ours, but also from many other organizations, that prolonged activity of the rectus femoris can contribute to a stiff knee gait. In particular, this abnormal prolonged activity in swing period is a particular sign. And if that's coupled with a slow slope on the knee curve, that's usually an indication that either a rectus femoris transfer or a rectus femoris release is an appropriate procedure. In this case, the distal transfer of the rectus femoris was performed, and the intent here is to not necessarily be you're actually taking the rectus femoris and moving it behind the knee joint, not necessarily to act as a knee flexor, but rather to remove its unwanted knee extension during pre-swing, which is interfering with the usual ballistic movements. And while theoretically it converts it to a muscle on the knee extensor, much of the research has shown that it really, the benefit of this is to reduce its effectiveness as a knee extensor at the wrong time in the gait cycle. So this young lady had this single rectus femoris transfer, and you can see that by doing a procedure like this, a rectus release is also a procedure that is commonly used for this. You can eliminate this knee extension moment at pre-swing and initial swing, and you can then return to a knee flex position of having sufficient knee flexion, 40 degrees at pre-swing and 70 degrees at initial swing. And as a result of that, she's able to, you no longer see the compensatory movements that you have. From a gait standpoint, these two recordings are at 8 years and then 1 year later, you see we have a significant improvement, about a 50% improvement in gait speed. GDI is a cumulative measure describing all of the kinematics. And we see we have a 5-point difference in GDI. Improvement in GDI is considered clinically significant. And we have about a 15-point improvement in GDI as a result of that. And so that indicates that she has an improvement in both walking performance, her walking speed, and her overall pattern as a result of that, because she's restored the critical events necessary to move forward. We actually have 9-year follow-up on this young lady, and you can see that this rectus femoris transfer is actually can be particularly stable. Her GDI actually has gone down, which means her pattern, but it's associated with this external foot progression angle and external rotation that she has that advanced over a period of time. Her knee flexion pattern is very similar. So this is just to show that if stiff knee gait is warranted, and you can show that there's the evidence from instrumented movement analysis, there is the potential to maintain an improvement over a long period of time. All right, so I have just one last example here associated with mid-swing, and that is a hip flexion to at least 30 degrees and a neutral ankle position. But the primary driver on this is having a neutral ankle position at mid-swing so that you can maintain foot clearance. For this particular subject, this is a 16-year-old with left transverse myelitis. So, and obviously the tibialis, she has trace strength out of the left tibialis anterior. So this is a characteristic drop foot or foot drop gait pattern that you see. So you are not able to maintain a neutral position, and you have excess plantar flexion throughout swing period. And you can see some compensatory movements. If you compare the right side hip flexion during swing period to the left side, you can see there's considerably greater hip flexion on the left side. That is a compensatory hip flexion, sometimes called a steppage gait pattern, to go ahead and help with clearance as she's moving forward. Again, since she has trace tibialis anterior, strengthening is not there because it's a myelitis. Electrical stimulation doesn't necessarily have a potential, although there is some potential for a walk aid. But the simplest and most reliable solution here is with an AFO. And so I think the important thing that I wanted to illustrate here is that with an AFO, you now have restored many critical events that cascade from that excess plantar flexion and weak tibialis anterior. You've restored a heel first initial contact during initial contact. You've restored the first rocker during loading response. And you've achieved this neutral foot alignment. And you'll notice that she no longer has as much hip flexion as a compensatory movement at this point. I couldn't get away without showing some gait graphs here. So this particular gait graph is a comparison first on gait speed. And you see that with the AFO, we get an improvement here in the stride length. This is pretty common when you have an AFO. You almost always get an improvement in stride length, so that for the same cadence, you get an improvement in walking speed. And in fact, her gait speed is above our normal level. The cadence actually even drops some, and we're able to leverage that into a good walking speed. So it's a great functional outcome of overall gait performance. And then this is GDI. Again, the GDI is on a 0 to 100 scale. It's a normalized scale where 90 to 100 is considered normal. And this is used to understand movement pattern. And on the right, I'm using something we call the movement analysis profile. On the GDI, bigger is better, 90 to 100 is normal. On the movement analysis profile, this is breaking down the individual contributions from the pelvis, the hip, the knee and ankle to this overall GDI. And the important piece here, again, this is gait pattern, this is kinematics. You can see that by restoring that critical event, you're actually reduce the residual using the AFO. And this is the foot drop at the ankle. You've reduced that considerably. And now you not only have improved the pattern on the right side by a small amount, you've significantly improved the pattern on the left side. And these graphs we use regularly to go ahead and get a more generalized gestalt of all the kinematic curves to make a decision. So I think I'm about out of time. And so I just wanted to go ahead and leave you in summary with this graph, this table. And this table has the stance period and swing period, weight acceptance, single limb support, and swing limb advancement. Feel free to utilize this table if it helps you to be able to identify the start and end of phases and identify what critical events occur during each of those phases. I found it very useful. And it's the guide that we use even when we have instrumented gait analysis. We always start with an observational analysis and then utilize instrumented gait analysis to fill in the gaps and give quantification for the severity of each of these conditions, but it doesn't eliminate what we do from an observational standpoint. I want to remind everyone that I am not a clinician, but I work with them and I've worked with them for very long. And I always want to acknowledge all of our clinicians at our facility, but especially our emeritus faculty who were here from the beginning of our laboratory. But all three of these, Amy Bodkin, our lead physical therapist, Frank Chang, our pediatric orthopedist, and Dennis Matthews, our pediatric physiatrist, have all retired in the last year. And so I've learned from them. It's their vision that has gotten us to the point we're at, and it's my hope to continue that vision as we go forward. So thank you for your attention.
Great. Thank you, Dr. Carollo. That was excellent. And I think we'd have a couple minutes for questions or comments. I see an initial hand up from Dr. Diab, one of our pediatric orthopedic surgeons.
Thank you, Dr. Carollo. I know that you ended with an apology that you're not a clinician. I'm a pediatric orthopedic surgeon, and since I've been in training from the 90s, we've been moving, or there has been an appeal to do more bone work to help the cerebral palsy patients. For example, in the hip, I think now it's pretty accepted that soft tissue work often will fail. It will fail in that a lot of the patients need backup bone work for their hip dysplasia. Have you seen that in the patients that you've taken care of and worked with the pediatric surgeons? For example, you showed us a distal femoral osteotomy rather than a hamstring lengthening and what have you. Do you get a sense that we're doing more bony work on these patients to help them rather than traditional soft tissue release, recontracture, soft tissue release?
Yeah, I believe so, and certainly in our group we have evolved the soft tissue work, in particular for hamstring lengthenings. The hamstring lengthenings and tendo Achilles lengthenings, both of those I say have, as we have grown with having clinical movement analysis as part of the portfolio for managing these kids with cerebral palsy, those soft tissue releases have decreased. I think we follow with the Gillette principles of being able to try to hold off, work on motor control the best we can early on, do soft tissue releases when there's clear evidence that the muscle is short, but then if it leads to bony deformity, certainly the first procedures that are done earlier are the hip procedures to make sure that we have proper coverage, and then later if it proceeds on to crouch gait, the knee extension osteotomies are becoming much more regular. We also do derotational osteotomies if there is an anteversion component and we track that using our transverse plane kinematics to be able, combined with the physical exam to make sure that we understand how much needs to be done at the hip, how much needs to be done at the tibia, et cetera, to achieve a more normal alignment from a rotational standpoint. So I would agree that we're tending to do that. We did more rectus transfers when we first started, and we felt that rectus transfers were an excellent solution. But now we have pretty tight criteria for when we do a rectus transfer. We need to see that dynamic electromyography evidence along with slope evidence of the knee curve to be able to have the intent to be able to go ahead and do those rectus transfers. And hamstring lengthenings, we will only do those if our muscle length calculation shows that they are short, and we'll often use either Botox or phenol as an intermediate to go, and along with stretching, to go ahead and try to get maximum hamstring length if the popliteal angles warrant it.
Thank you.
And then Dr. Vale.
Yeah, thanks. Dr. Carollo, Tad Vale here. I'm the department chair, and I just wanted to thank you for mentioning Dr. Inman and Dr. Perry, and say how relevant and fundamental the concepts that you brought today are to practice. Dr. Perry's book also includes all those simpler drawings. Particularly, I found them useful in understanding rotational abnormalities, how one joint affects the next, and from the ankle to the hip. And I recommend that to all the learners that may know the names but haven't looked at those books. It's well worthwhile, and I still use those concepts today in my lower extremity reconstruction practice. So just a word of thanks to you and to our physiatry colleagues for inviting you here today.
Well, thank you very much. Their work is timeless, and I think that all of us in the Gait community are thankful that Dr. Perry and Dr. Sutherland were both residents of Dr. Inman's, and that infected them and really has led to the use of instrumented movement analysis to make these decisions, and in our belief, to the betterment and to improve the quality of life of these individuals.
I see a hand up from Dr. Pasquale, and then there's also, maybe we'll take the comment in the chat first from Dr. Kapadia. Just the statement that the Shriners Sacramento group uses observational gait analysis, and then also looking towards smartphone technology.
Right.
And do you have thoughts on incorporating that where like the full spectrum of instrumented gait analysis may not be an option?
No, absolutely. And Dr. John Davids there is very well known for advocating, and we certainly support that. One of the reasons I didn't want to be heavy on the instrumented gait analysis side for this is to remind everybody that's not the only way to do movement analysis. If you understand these fundamental principles that Dr. Perry laid out, and you utilize tools like they're developing at Shriners in Northern California, you can do a tremendous good, because it gives their system. They're using some of the Edinburgh assessment criteria, but that observational approach is essential, and we do it every day. Even though we have all the graphs, we always go ahead and start with an observational assessment. So yes, I think the fact that you can do it, and they're putting it down to an app to make it even more accessible. In my view, I would love for movement analysis to be ubiquitous. We're interested. Some of my work is related to mobile devices and what we can get with simple IMU-based or motion sensor-based devices that can give us timing of information. Because if there is a gait abnormality, it will show up in an asymmetry in the temporal distance measures. And I'm hopeful that we can get that in many different environments, in clinic environments, in rural environments that may not have a full motion lab. I'm not trying to put our motion labs out of business. I'm interested. I think it's a spectrum of movement analysis that involves qualitative assessment, observational movement analysis, and some perhaps lower fidelity quantification that can be used so that more we can have the benefits of movement analysis far beyond the Gait laboratory.
Great. And just in the interest of time, I think we'll wrap up with Dr. Pasquale.
Yeah, I just wanted to again thank you for spending all of this time with us. I know that I'll have a lot of takeaways, and I'm going to be referring back to this Grand Rounds, your slides, and all of the information and the graphs that you provided us. So we really do appreciate it. We wish that we could have hosted you personally, and unfortunately we weren't able to, but in the future, if you ever come by our way, we'd love to see you in person. And again, I just want to extend our thanks for all the time that you spent with us today.
Oh, it's been my pleasure. I was looking forward to coming there as well, and maybe we'll have an opportunity to do it again in the future.
Great. Well, thank you again, Dr. Carollo. This was excellent, and we definitely all appreciate it. And we will be off next week for Thanksgiving, but hope everyone enjoys the holiday, and we will see you back in December.
Very good. Thank you.
Thanks, Jim. Bye.
Bye.